Xin chào tất cả các bạn. Các bệnh lý về nhân giáp và ung thư tuyến giáp ở nữ giới thường cao hơn ở nam giới. Một số nghiên cứu cho thấy rằng ung thư tuyến giáp xảy ra ở nữ giới có thể cao gấp 3 lần so với nam giới. Vì vậy, việc phát hiện các bệnh lý này trong quá trình mang thai cũng không phải là ít và đôi lúc sẽ gây ra sự lúng túng trong thái độ xử trí. Có nhiều câu hỏi đặt ra như khi phát hiện nhân giáp trong quá trình mang thai có cần phải can thiệp hay không và khi nào cần can thiệp. Tương tự, nếu như ung thư tuyến giáp xuất hiện trên bệnh nhân có thai thì có cần phải phẫu thuật ngay lập tức hay không, hay là có thể trì hoãn điều trị. Hôm nay chúng ta sẽ được bác sĩ Trevor Angel sẽ trình bày cho chúng ta về các nhân giáp và ung thư tuyến giáp trong thai kỳ. Hy vọng qua bài trình bày này các bạn sẽ trả lời được câu hỏi trên. Mời các bạn cùng lắng nghe.
Okay, it is a pleasure to be here today. Hello, everyone. Thank you to the organizers for the invitation to speak on thyroid nodules and thyroid cancer in pregnancy. I don't have any relevant financial disclosures related to this talk. As far as our objectives, I really want to go through what we know about the presence and risk of thyroid nodules related to pregnancy and evaluate the prognosis of thyroid cancer during pregnancy, really to get to the point where we all can perform the management of thyroid nodules and thyroid cancer in pregnant persons. So if we start off with a case that I think will be very typical, a 32-year-old G0P1 woman who's seen for a first visit at 10 weeks gestational age. The only abnormal finding is a palpable thyroid nodule. She has no compressive neck symptoms or evidence of thyrotoxicosis. An ultrasound is performed that shows a 1.4 centimeter solid hypoechoic nodule that would be considered intermediate suspicion by the ATA sonographically, or TIRADS-4. A TSH is measured that is 0.12 milli-international units per liter, which is slightly low. And we might think about management options, such as performing an FNA biopsy, repeating an ultrasound later on in the pregnancy, performing a radioiodine uptake and scan, or simply reassessing after delivery. And so, looking at what we know about this entity to help guide us along on what maybe is the best choice. So what is the effect of pregnancy on nodular thyroid disease? So the identification of thyroid nodules is quite common during pregnancy, and there are some potential explanations for this. One might be that in an otherwise healthy person, pregnancy may just represent a time when they come into contact with doctors and have a pre-existing thyroid nodule identified. And this might be furthered by an increasing incidence in women during pregnancy related to age. And then additionally, there may be some true underlying relationships between pregnancy and thyroid nodules. So if we just look at the prevalence of thyroid nodules with age, this graph shows the percentage of people with a palpable thyroid nodule, and on the x-axis age, and we can see that through the decades, thyroid nodules become more common. And we can pair that with data that shows that the age of first birth in pregnant persons is going up as well. So we would expect to perhaps find a greater frequency of thyroid nodules in our pregnant patients just because of this relationship with more advanced age. There have been several studies that have looked at thyroid nodule presence by ultrasound evaluation in people who are pregnant. This has shown that the prevalence of thyroid nodules could be quite wide depending on the definition, anywhere from 3% to about 20%. And certainly the mean age was older in women with thyroid nodules compared to without. The figure on the right-hand side is showing the relationship between thyroid nodules and parity. As you see, the prevalence of thyroid nodules in nulliparous women, about 9%, with a highest prevalence in those with 3 to 5 pregnancies, although this wasn't adjusted for age. So that's a confounder. If we evaluate thyroid nodules monitored during pregnancy, some data would say that up to 60% may double in size, although many of these were very small and remained very small even though they grew. And this figure here showing the volume of thyroid nodules indicates that during the trimester, there's an increase in nodule size that actually regresses a bit after pregnancy. This figure looks at the number of thyroid nodules that was found on ultrasound during pregnancy. And this also shows an increase in the number of nodules during pregnancy and then stability postpartum. So if a nodule forms, it doesn't regress. And one prominent hypothesis is that this relates to the estrogen state of pregnancy that does have some influence on the thyroid gland. But whether or not these nodules represent anything clinically significant is debated. As I said, most of them are going to be very small. So what is the risk of thyroid cancer associated with a thyroid nodule that might be found during pregnancy? This is a very important question. We know that thyroid cancer is one of the most common malignancies to be diagnosed in reproductive age women. So certainly someone who is pregnant is likely to be at risk for a thyroid cancer diagnosis just based on their age. Large population-based data looking at the incidence of thyroid cancer indicates about 14.4 per 100,000 pregnancies, with the majority of those diagnoses being in the postpartum window. And whether or not that was when they were identified or just when they got evaluated in the postpartum period isn't known. Small studies looking at thyroid nodule evaluation in pregnant patients have indicated a pretty wide range of thyroid cancer risk. Studies that say 12% to 15% might be on the slightly higher end, but not unexpected, whereas another study where there was 43% risk would be quite a bit higher. But we can recognize that these were quite small samples, and there's certainly the possibility of selection bias in which women were being evaluated during pregnancy, probably having some higher risk for some reason to lead to the diagnosis. Now, this slightly blurry table, these are data from Los Angeles County done by Wendy Mack and colleagues, which looked at thyroid cancer risk in a very robust way and reassuringly found that in multivariable analysis, ever pregnant or number of pregnancies neither were associated with thyroid cancer diagnosis. So based on these data, how should thyroid nodules found during pregnancy be assessed? And we start to get into what recommendations exist to help guide our clinical practice. And in the United States, documents from the American Thyroid Association cover this topic, both in the 2015 management guidelines for thyroid nodules and differentiated thyroid cancer, and the 2017 guidelines related to the management of thyroid disease during pregnancy and postpartum. So this would be a very general algorithm for assessing thyroid nodules, very familiar, that a possible thyroid nodule would be evaluated by ultrasound to confirm the presence of a discrete lesion, and then a serum TSH would be assessed. When TSH is low, generally we are thinking about radioactive iodine uptakes and scans and potentially finding a hot nodule. But of course, this is not available as a test to do during pregnancy because of clear risk related to radiation exposure. So we'll come back to how we might deal with that scenario. For people with a non-suppressed TSH, that's people who are either euthyroid or hypothyroid, the assessment for malignancy would continue. And so for low TSH in pregnancy, the recommendations would be that if a low TSH persists beyond 16 weeks, then FNA biopsy may be deferred, returning to this after pregnancy and cessation of lactation to do a radioactive iodine uptake and scan if the TSH remains suppressed to evaluate if this was a hot nodule. Otherwise, thinking about those cases where we're assessing for malignancy, the recommendations would say to perform FNA on clinically relevant thyroid nodules in pregnant patients. And the determination of which thyroid nodules would require FNA would be based largely on the sonographic pattern, consistent with more general recommendations. So I've put up here the American College of Radiology TIRAD system, which may be familiar, and since it is used by many radiologists, is often found at the bottom of your ultrasound report, where features are looked at, and the more suspicious they are, the more points they get, and the more points, meaning greater level of suspicion, would lead to a recommendation for FNA more and more aggressively. Fortunately, performing neck ultrasound is safe in pregnancy, as is performing an FNA biopsy. And additionally, nothing about pregnancy seems to alter the cytologic diagnoses that are made by a fine needle aspiration cytologic assessment. So once we have an FNA biopsy, we would ask, how should thyroid nodules that have undergone an FNA be managed during pregnancy? And that's obviously going to depend on our result. So we get back a thyroid FNA cytology, and one result could be that it's a benign cytology. And the recommendations here are that these don't require any special surveillance during pregnancy. Routine surveillance would be to repeat an ultrasound after 1 year, if not longer. And so that would essentially mean that the thyroid nodule would be reassessed after completion of pregnancy. Cytologic results that are deemed indeterminate, these are categories that have a low to moderate risk of malignancy, but it is not excluded or confirmed, do not require surgery during pregnancy, but likely should be monitored and surgery considered if there is evidence of more aggressive behavior. And we'll come back to that a bit when we talk about cancers. There is molecular testing, which is further evaluation on the cytologic material for indeterminate cytologies, but this is not currently recommended for pregnant patients, largely because of lack of data on these tests in pregnant populations. And then finally, we can think about those patients who are diagnosed with thyroid cancers. And in the rare situation where these are aggressive thyroid cancers, say medullary thyroid cancer or poorly differentiated thyroid cancer, we would really be thinking about intervention and surgery. But the vast majority of these are going to be well differentiated thyroid cancers, predominantly papillary thyroid cancers, where the clinical course can be much less aggressive. And so we're really going to talk about those cases. Then we return to our 32-year-old woman, now at 12 weeks, with her 1.4 centimeter nodule. An FNA biopsy was performed, and we get back a cytology that's positive for papillary thyroid cancer. So what management options would we be considering? Surgery right away. It seems like it would be desirable. Repeating an ultrasound in the second trimester, or maybe just saying we're going to wait on surgery until after pregnancy. So what might color our thinking to make this decision? What's the case for immediate intervention? I mean, one would be patient expectation. I think many times someone who hears that they have a cancer would be by default thinking that the treatment for this needs to be immediate. Some data have also indicated that these might be more aggressive cancers. And so this is a study from Italy, a retrospective study of women with differentiated thyroid cancer that was evaluating the rate of persistent or recurrent disease. They found patients who were diagnosed after a year postpartum, during pregnancy, or before pregnancy, or without pregnancy, and put them into these three groups. And as you can see in the figure on the bottom, the middle group, which is the during pregnancy group, had a much higher rate of persistent or recurrent disease. In a second study that was very similarly designed of women who had undergone total thyroidectomy and radioactive iodine ablation for differentiated thyroid cancer, they had three groups. One was diagnosed far after delivery. The second group was during pregnancy or in a early, less than 2-year window after pregnancy, and then a group without pregnancy. And similarly, if you look at the figure, the middle group, which was deemed sort of pregnancy associated, had the greatest risk of thyroid cancer persistence after treatment. So these data would be interpreted to mean that these might be more aggressive cancers in need of more immediate treatment. However, there are some big limitations to think about. These were both small retrospective studies, and between the two studies, they conflicted in some ways. The rate of recurrence was much different, with the first study having a really high rate compared to what we would expect. The second reason was the criteria that recurrence was judged upon. The two studies differed in whether or not patients had positive lymph nodes, in whether or not they had elevated thyroglobulin, so there wasn't real consistency. And then third, looking at the potential mechanisms, one study found an association with estrogen receptor status and aggressiveness, while the other did not. So they don't really confirm a biologic plausibility. On the other hand, what would be the case for delaying intervention? And these are a series of somewhat landmark studies that we'll look at. The first being from the New Mexico Tumor Registry, in which women diagnosed with differentiated thyroid cancer during pregnancy were compared to non-pregnant patients. And in those cases versus controls, there was no observed difference in the survival of patients. In the next study, there were 60 women with DTC diagnosed during pregnancy compared to a large cohort or control group of age-matched non-pregnant controls. And what we can see is that there was no difference in the presence of lymph node metastases, of recurrence rate, or the presence of distant metastases. And then finally, from the California Cancer Registry, quite a bigger group of almost 600 women diagnosed with thyroid cancer during pregnancy or within 12 months, compared to age-matched non-pregnant controls, showing no significant worsening of survival distribution over time in pregnant individuals. And then finally, importantly, looking at recurrence, which is what those previous studies had hinted at. This more recent data from Australia in women diagnosed with papillary thyroid cancer during or relatively close to pregnancy, compared to age-matched non-pregnant controls. And looking at disease-free survival, found no significant difference between the two, which is additionally very reassuring result. And then another consideration would be reducing the risk and thinking about that risk-benefit ratio. in a very important study looking at pregnant patients versus age-matched non-pregnant patients who underwent thyroid or parathyroid procedures. What this figure is showing is that the pregnant population was significantly more likely to have a number of adverse effects or complications when they underwent surgical procedures. So guidance at present is that differentiated thyroid cancer, predominantly papillary thyroid cancer, that's detected in early pregnancy should be monitored sonographically. And if there is substantial growth or evidence of aggressiveness, and that could be lymph node spread that is identified or extrathyroidal extension that is identified, this is before 24 to 26 weeks gestational age, then surgery should be considered and done in the second trimester when it is safest to do so. If a intrathyroidal tumor is stable at mid-gestation, then surgery may be deferred until after delivery because it appears to be an indolent behaving thyroid cancer. So what is my personal perspective on this? I think we need to look at thyroid nodules identified during pregnancy as quite a low-risk finding and be able to provide a lot of reassurance. And I think we really need to base our decisions on the sonographic evaluation. And I would even include in this women with a suppressed TSH without any evidence of thyrotoxicosis. We know that TSH will physiologically be lower due to the effects of pregnancy, and that may lead us to defer evaluation because of that possibility of a hot nodule. But if sonographically it is very high risk, I think that should be evaluated as a potential malignancy and likely biopsy be performed. But additionally, I think the decision should be based on a patient-centered discussion. Some people may really wish not to have intervention and defer. Some may really prefer to have answers earlier. Some may even be in a situation where performing the procedure before having a baby would simply be more convenient and preferable. But regardless, I think there should be strong preference for delayed surgery based on the present data that would suggest that the outcomes are largely similar, particularly with respect to survival, and that the risks of performing surgery, even when done ideally, are greater. So how should patients with thyroid cancer that is first diagnosed and treated before pregnancy be managed during pregnancy? And we can look at the risk of progression during pregnancy in such patients. And one retrospective study of women with papillary thyroid cancer monitored during pregnancy, if there was no thyroglobulin or positive ultrasound findings before pregnancy, there were no recurrences observed. In a second study of 63 women who went through pregnancy and gave birth after a diagnosis of papillary thyroid cancer, there are 6 of the 13 women who had persistent disease before pregnancy did show progression, either anatomic or based on thyroglobulin. But no progression was seen in patients who were considered disease-free before pregnancy. Some recent data from 2021 looked at women who had differentiated thyroid cancer and had undergone radioactive iodine treatment with the presence of lung metastases. And they found 37 of these patients who had pregnancy after treatment, compared to 87 patients who received this treatment but did not have a later pregnancy. And they found that there was no difference in progression-free survival or overall survival in patients with lung metastases who became pregnant compared to those who did not. Now, this is the figure of all the patients in that study, and I will note that there were a couple of patients with pulmonary metastases where the size of those did increase somewhat significantly, and I think there is some recognition that there is the uncommon but possible risk of progression during pregnancy, as is seen in some cases. And so I think the recommendations that exist at this point are very good, that monitoring during pregnancy for women who have a history of thyroid cancer is not required if there is no evidence of disease, such as undetectable imaging or thyroglobulin levels, but that monitoring should be performed in pregnant patients who have elevated thyroglobulin or known sites of persistent disease. So I will touch on how should TSH be managed in pregnant patients with a previous diagnosis of thyroid cancer. Current recommendations are that pregnant women with thyroid cancer should be managed at the same TSH goal as was determined pre-conception. This would be in order to best facilitate the management of their thyroid cancer, and there does not appear to be significant risks associated with this, showing in the figure here just the physiologic reduction in TSH that happens during pregnancy. So my final summary to answer a few questions. Does pregnancy influence thyroid nodule formation and growth? Probably it does, although there may be very little clinical significance to this. Is pregnancy a risk factor for thyroid cancer? Probably not. The majority of data would suggest that their risk is similar to the underlying population. Does thyroid cancer diagnosis in pregnant patients have an adverse effect? Maybe. I showed that there was a little bit of data to point to that, but certainly the majority of data is reassuring, particularly with respect to survival. Does pregnancy increase the risk of differentiated thyroid cancer when there is no evidence of disease? Rarely, if ever. But does pregnancy increase the risk of thyroid cancer when there is persistent disease? It often can, and these patients would need to be monitored closely. That is where I will conclude, and I'll look forward to the Q&A. Thank you very much.
Vâng, bài trình bày đến đây đã kết thúc. Cảm ơn các bạn đã chú ý lắng nghe. Nhớ like, share và subscribe để theo dõi các bài học tiếp theo. Xin chào và hẹn gặp lại.